Ozempic and Wegovy, both Semaglutide, or Mounjaro and Zepbound, both Tirzepatide, can change mood. Evidence is more reassuring than the headlines suggest. It does not show a broad increase in suicidal thoughts. But a real mood change still deserves attention because timing matters more than panic. The key is separating research averages from your own week, not headlines alone. Mood is harder to judge than nausea or constipation. A stomach symptom has a location, a pattern, and a simple timeline. Sadness, anxiety, agitation, or emotional flatness can feel like the medication changed the person. That fear makes every online story feel urgent. But the research question is narrower than the fear. These drugs affect appetite signals in the brain, so mood questions make sense. The real question is whether they increase mental health harm compared with similar patients using other treatments. That comparison matters because obesity, diabetes, poor sleep, chronic pain, and stigma around weight already affect mood risk. I'm Dr. Kim, a licensed physician. Those background risks are why large studies and one patient's timeline both matter. This is not medical advice. Consult your doctor. These medicines copy a gut hormone called glucagon-like peptide 1, which helps regulate appetite and blood sugar. That hormone also signals in parts of the brain. A brain signal does not automatically mean brain harm. It means the gut-brain connection makes the question reasonable, not proven dangerous. Because a reasonable concern is not proof, researchers need fair comparisons with people not taking the drug. Regulators looked because serious reports existed. Reports can start a safety signal, but they cannot prove cause by themselves. Larger comparisons are needed before fear becomes an official warning. Those larger comparisons have been reassuring. The latest United States review found no increase in suicidal thoughts, suicidal behavior, anxiety, depression, or irritability. That comparison used placebo, an inactive comparison treatment. European reviewers also concluded that available evidence did not support a cause and effect link. So the public story should become narrower, not louder. These drugs do not look like a hidden mental health threat for the average patient. But average data cannot decide what is happening inside one patient's week. The data should reduce panic, not erase symptoms. If a mood change is new, severe, or tightly linked to dose timing, it deserves attention. Mood can shift through several routes during treatment. Those routes can feel identical inside, so separating them matters before any dose decision is made. One path starts with appetite and reward. Reward means the brain's pull towards something that feels comforting or satisfying. Some patients feel relieved when cravings become quieter. Others feel strangely flat when favorite foods stop giving comfort. That flat feeling can be confusing. The drug may not be causing depression directly. That confusion is worth naming before assuming the drug is the cause. Most people expect mood to improve if weight loss starts. That is often true, but not always. The uncomfortable truth is that some patients feel worse after appetite improves. The reason may be that food was doing emotional work before treatment began. Another path runs through the body. Side effects can worsen mood even when the drug is not directly causing depression. If nausea limits food, hydration, protein, and normal life, mood can worsen through physical stress first. A person may feel anxious or irritable before calling it a mental health problem. A third path is social. A person who used restaurants, desserts, or late-night snacks for connection may feel unexpectedly disconnected. That does not mean the medicine harmed the brain. It means the routine around comfort changed quickly. The same treatment can also improve mood indirectly. A person may sleep better after weight loss. Blood sugar may become steadier, and knee pain may improve. Shame around eating may decrease. So the real question is, which path is driving the change? Because mood can change for several reasons, timing becomes the most useful clue. Write the dose, injection date, appetite, protein intake, fluids, sleep, bowel pattern, and mood symptoms. Also, write any new medicines. A pattern after a dose increase means something different from a mood change that began months earlier. Other substances can confuse the timeline. Medicines used for mood, sleep, or attention may be changing at the same time. Steroids, stimulants, sleep aids, cannabis, heavy alcohol use, or sudden alcohol reduction can affect mood. Mental health history changes the monitoring plan. A past episode of depression, panic, self-harm, or bipolar disorder needs closer follow-up, not automatic exclusion. Bipolar disorder can include depressive lows and unusually high energy periods. Usual mood before treatment and a clear rule for when to call the doctor are sensible safeguards. The real test is not how the medication looks online. It is whether the patient's function is improving or shrinking. Eating, drinking, sleeping, working, answering messages, and leaving the house are practical signs. Weight loss is not a success if daily life quietly collapses. A simple baseline makes later changes easier to judge. Before starting, write down sleep quality, anxiety level, usual mood, alcohol pattern, and support at home. This does not need a formal test. It creates a before and after picture when memory becomes blurry. That baseline matters even more for higher risk patients. Recent hospitalization, active suicidal thoughts, rapid medication changes, or manic episodes should not be handled casually. Manic episodes are periods of unusually high energy with risky behavior. In those situations, the doctor and mental health professional should coordinate before the dose plan keeps moving. Outside the clinic, family members can watch daily function. Look for missed calls, skipped meals, poor hygiene, unusual agitation, impulsive spending, or staying in bed most of the day. Function often changes before people can clearly name the emotional shift. For practical decisions, stable mood can usually mean routine monitoring. Feeling emotionally flat after appetite loss deserves discussion, not panic. Worsening depression after a dose increase should pause the next increase until the doctor reviews the timeline. The choice is not simply continue or stop. The next step may be holding the dose, treating constipation, improving hydration, reviewing sleep, or delaying the next dose increase. Stopping can be right sometimes, but it should not be the only tool considered. Dose decisions should protect function, not only weight loss. The goal is not the strongest dose a person can tolerate. The goal is the lowest effective plan that supports weight, blood sugar, nutrition, sleep, and daily life. A smaller life is not a better outcome. Doctors need both kinds of information. Do not blame the injection for every mood symptom. Do not ignore a clear decline because weight loss looks successful. The right question is whether the patient's timeline, side effects, history, and dose pattern fit together. A good check-in uses direct questions. Ask about hopelessness, isolation, sleep, agitation, and self-harm thoughts after each dose change. Direct questions do not create suicidal thoughts. They make dangerous changes harder to miss. Routine monitoring has a limit. New suicidal thoughts, self-harm thoughts, reckless behavior, severe agitation, or sudden withdrawal need urgent help. In the United States, call or text 988, the Suicide and Crisis Lifeline, for immediate self-harm risk. Do not wait for the next weight loss appointment. These drugs are not a mood villain, and they are not a mood cure. They are powerful metabolic medicines that deserve mental health monitoring. Research can lower fear, but your week still matters. The rule is simple. Keep the treatment, but do not lose the person. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.